Waiting times of 40 hours, ambulance queues, overworked staff, and desperate patients. Over the winter, the NHS was under extreme pressure. But even out of the grip of that crisis, even on an average day, the pressure in one of the country's biggest hospitals is palpable.
That patient will need neurosurgical intervention, so one of the next things will be is to manage that, to get them to theatre as quickly as possible to resolve that for them.
In a rare glimpse inside the NHS, a few weeks ago, Stories of Our Times visited Addenbrooke's hospital in Cambridge.
That patient sustained, I can see there's a big bleed, this white area. Here, there's a hemorrhage there, which has happened. I imagine it's caused by trauma.
When was the last time the NHS felt like it was on a stable footing?
It hasn't felt normal since before COVID. Yeah. And actually, this is probably the worst that I've ever seen. Something needs to change desperately.
Adding to the day-to-day pressure, right now, we're in the middle of a 3-day strike by junior doctors over pay. It could be the biggest disruption to services in England so far.
A doctor that's gone through medical school, done a minimum of 5 years, graduating with £100,000 of debt, is being paid £14 an hour.
Meanwhile, could pioneering technology help to ease the pressure?
With robotics, all of a sudden I was able to do the same operation through 3 or 4 small cuts in the tummy. Your recovery time goes from 4 to 5 days down to 1 day or possibly 2 days.
That's amazing.
So there's definitely...
It's better for the patient, better for the NHS.
Yeah.
You're listening to Stories of Our Times from The Times and The Sunday Times. I'm Manveen Rana. Today, 48 hours on the NHS front line. It's a frosty morning in the east of England.
We are now approaching Cambridge.
And the Times columnist, Rachel Sylvester, is just starting the first of many hospital visits as part of a year-long project for the Times. The Times Health Commission is looking at how problems in the NHS could potentially be fixed.
I've come to Cambridge to Addenbrooke's hospital to see a big hospital in action for the Times Health Commission. And I'm really interested to see how it's coping with the crisis, what the pressures are, but also to see what they're doing differently, because this is a hospital that's using a lot of technology, a lot of innovation. They've got a robotic surgery, they've got virtual wards, they're using AI. So I'm keen to know what we can learn for the rest of the NHS, what's working here and also what isn't. So far it seems pretty quiet. There's a few people waiting in A&E, but it's early in the morning, so we'll see. Hello.
It's Rachel.
Hi, nice to meet you.
Now we need to find somewhere for...
Rachel, you've just spent 2 days at Addenbrooke's hospital in Cambridge, and it's one of the biggest hospitals in the country. You've been looking at a lot of aspects around the hospital and how it works and the pressures they're under. Talk us through one of the key pressure points in A&E. What was that like?
So I spent some time in the emergency department, which is the most acute bit of the hospital, where the ambulances arrive, the air ambulances, very tense atmosphere, calm but tense, I'd say.
My name is Diane Williamson, and my job title is an emergency medicine consultant, and I'm the specialty lead for emergency medicine. We have to respond to each and every patient who arrives, so there's a continuous need to evaluate who has the greatest need and who needs the resources
and there's
urgently.
Some really difficult decisions then involved.
Always,
so we were
yes,
talking about
yes.
Patients who can't come in from ambulances or treating patients on trolleys and things like that. How does that feel?
These are really difficult decisions, and they're made every day. It's not an exaggeration to say that those decisions will have been made multiple times, even by this time today. And
I went to their operations meeting in the morning when they're giving the update on who's arriving, who's leaving, what's happened.
On that spreadsheet
It's a massive spreadsheet, colour coordinated.
Colour coordinated spreadsheet. It's got colours on it specifically: green, amber, red, and black. Okay. It's what we
The screen in front of the doctors and nurses was full of these black and red boxes. It's supposed to be green, or if things are starting to get under pressure, amber. But the spreadsheet was absolutely covered in red and black boxes. And what that meant, red means under serious acute pressure. Black means they can't operate anymore.
change, and then on the black means we aren't able to function in a situation normal. We need to make adaptations to our work.
So what's black on that board now?
Caroline, can you tell us what's black on the board at the moment?
It will be waiting time for the specialities, attendances that we've had in the last hour, the amount of red trolley spaces, the amount of patients that we've had in the urgent treatment centre.
And it was, to me, that was really shocking. How many ambulances are out there? Have you got anyone waiting at the moment?
It looks like just the one.
Okay.
And we've got 6 en route.
Oh gosh.
So you can see the 6 that are en route. And
You know, there were ambulances coming in, 3 beds. Already you saw 2 patients were on trolleys in the corridor. There was an elderly man lying in a draft from the door out to the ambulance bay. I saw a man coming in, he'd had a heart attack.
that patient's very likely we will have received a phone call to say there's a sick patient arriving, and they'll be directed directly through to resus. So we will have, with a heads up, we will have made
So they
a
will
space
have
for
run
them to.
999.
Yep.
Got the ambulance.
Got the ambulance. The ambulance will have picked up, said concerned about this patient. They will have alerted us that there was a patient who needed to come directly into a resus bay.
Already a passerby had resuscitated him and used a defibrillator to save his life. Then the paramedics had got his heart going again in the ambulance, and he was rushed straight into resus. But there's enormous pressure, and a young woman then soon after was wheeled in. She was awake but looking very distressed, propped up on a trolley, and there's no space for these patients.
Because physically our estate just doesn't have the capacity to have enough rapid assessment bays. We think
So it's
for
not
the
really a corridor,
well, it is a corridor, to be honest. It is a corridor. It has no privacy. It's cold. It's a corridor.
In order to find a bed for them, they have to move somebody else on into another ward, but there's no space in the wards because other patients can't be moved out into the community, partly because of the lack of social care. So there's a lot of attention put on to A&E, the ambulance is queuing up outside the emergency departments, but actually it's about the flow through the whole system.
I mean, that's remarkable. That just sounds incredibly stressful.
The other thing that really struck me is how important the managers are in the whole thing. So there's a lot of talk about how the managers are just pen pushers and bureaucrats and absolutely pointless. But actually, they are running around making sure that doctors and nurses can do their job and trying to manage this flow through the system. And without them, I think things would be even worse. It's like a moving jigsaw where the picture's changing all the time, and it's almost impossible ever to get all the pieces in the right place.
I mean, tell us a bit about these managers, because, I think people outside, you're right, have an image of them as pen pushers. Tell us a bit about the managers that you met.
So I met several. One of them who sticks in my mind, Nicola Ayton, the Chief Operating Officer.
So I'm Nicola Ayton, and I'm the Chief Operating Officer here at Cambridge University Hospitals. Okay. I've been here for 5 years now.
She was wearing this very elegant sort of green shift dress, but with trainers, so she could run anywhere at a moment's notice.
And I'm really responsible for the day-to-day running of the hospital, all of our clinical operations.
And she had previously worked at the Treasury and at Number 10, and she's now come into the NHS. Just tell me how it's been over the last couple of months. I mean, we've seen so many pictures of crisis. Has it felt like that here?
So I think the first thing to say is what's really important is that we've been planning for this for a number of months. So way back in the summer, we had, it was really clear there were some good leading indicators to show us that this winter was going to be particularly tough.
Yeah. She said they knew that there was going to be a winter crisis right back in the summer, and they've been putting plans in place. But particularly in the week between Christmas and New Year, they were just overwhelmed. Did you end up with patients on trolleys for long periods during that kind of week between Christmas and New Year?
We did experience longer waits in the emergency department in the run up to Christmas and then between Christmas and New Year than I would want and then we would normally have.
What was the worst day?
We will have had waits between sort of 20 and up to 30, 40 hours on occasion.
People waiting 30, 40 hours for a bed, and even their best plans were blown away by the scale of the problem. Mixture of the fallout still from the pandemic and then a spike in flu cases, along with the kind of normal routine things that happen. But she said,
you know, the catastrophization or the use of that sort of lexicon around crisis within the NHS is really problematic. I mean, first of all, it's just factually, you know, incorrect. So actually, this is overall across the NHS, including here, this is a service which is under pressure, but that is bearing up, you know, is continuing to provide care that improves and saves lives every day, albeit with lots to do. We need to evolve, we need to keep innovating, and I think you'll see that today.
Addenbrooke is a major trauma centre for the east of England, and they also a specialist hospital for cancer, organ transplantation, genomics. So they are really in the thick of the crisis, but also trying to pioneer new strategies and techniques.
On the day that you were there, was this a particularly critical day? Was this, you know, is this standard now?
What in a way was most shocking is this was a very normal day. How does this compare to a typical day?
So I think it's quite typical, actually. I mean, we've had much more difficult days where we haven't been able, you know, where we've been really struggling ambulance by ambulance. But today, it seems like a fairly typical or less busy than typical day.
Yeah,
but
you've
what's
got
hard to say is what will happen.
Of blacks and reds on the
That's
board.
right, and that's typical.
So that's typical. Okay.
20 to 3 in the afternoon as well is a time when we generally see that the attendance will rise now. And as you heard, we've had an excessive number of patients in the last hour, and that's what usually happens.
There was no major incident, no road traffic accidents, no major terrorist incident, but actually through the day you could see the tension rising. And one of the doctors,
Stephen Wallace, with a PH and then an IS in Wallace, and I'm the divisional director and a geriatrician.
Steve Wallace, said to me,
you know, what it feels like now is almost like the line out of Narnia, you know, it's always winter and never Christmas. And actually, you know, like the height of last summer felt like the worst winter that we'd faced in the NHS. And, you know, and clearly this has been one of the most challenging winters that we've ever faced, with, you know, the misfortune of having COVID and flu surges all happening at the exact same time.
at a time when everyone's exhausted.
Yes, and again, normally we'd be hoping that spring is going to bring a bit of a let up, but you know, I think the anxiety that I carry is we didn't see that last year. You know, is there really the hope that actually, you know, get through the next couple of months and things will get easier? You know, I think we probably would be kidding ourselves.
It's less likely now. I think we haven't built the resource to the level we need to build it to experience a better spring summer period.
They've been through the pandemic, then the vaccine came, there was an end in sight, but now it's just this relentless, endless crisis. They're absolutely exhausted.
I mean, they must be. Did you get a sense of how much it's affecting them?
What was really striking, actually, was the impact on the mental health of the health professionals. So they are trained to save lives. They're trained to do the job they love, which is caring for patients. And too often they feel as if they're being thwarted. And Terry, what was the toughest moment in that, in the kind of real height of the crisis?
So if we think about December, there were two periods in December where we escalated to what we call a business continuity incident.
Terry Hicks, who's from the East of England Ambulance Trust.
Huge numbers of patients. As a regional organisation, I think at one point we had just over 600 patients waiting regionally that we didn't have an ambulance to send to. And some of those waited a long time. And because they waited a long time, their conditions deteriorated. So for me, knowing that we couldn't get to patients, because we were delayed to get to patients, their conditions were getting worse. That's really difficult as a clinician, to know that you're part of a system that's not able to do the right thing for the patient that's calling for help. And for those patients that call for help, we are often the last port of call. They don't know what to do. Patient doesn't know what to do, where to go, but calls 999 because we're always there. and we couldn't get to them. So from a clinician sitting in an ambulance, hearing the calls going out, there's another patient waiting, is one thing. But in the control room, the calls are coming. The clinicians that we have in our control room are having to make decisions on who gets the next ambulance. It wasn't uncommon for a crew to go and pick a patient up first thing in the morning. They would still be sitting outside the hospital at the end of their shift and beyond, because they hadn't been able to get into the hospital because the hospital wasn't able to. So the flow wasn't there, which then reduces our resource availability, and it means that patients aren't getting. So every day it was compounded.
As a clinician,
horrible position as a clinician to know that you can do something, but you're prevented from doing that because of the circumstances of the system. It's a very, very difficult place to be as an individual clinician. The moral injury that our crews have had, and our call handlers and our clinicians in the control room, it takes a toll.
Moral injury. It's the same for the nurses, it's the same for the doctors.
So it takes a long time.
Does it feel harder now than during the pandemic?
I think it feels that it's so persistent. I think for those of us in emergency medicine, the issue is not that it's harder in a sense. I think that would be hard to define, but I think it's the fact that there's been no respite for our service, because we were at the front line through the pandemic, and we're still at the front line, but it's for a different reason. And I think what I feel from my whole team is that fatigue and that sense of having dealt with this for a very, very long time, and in a way which, what happens is it deteriorates your ability to offer the care in the way that you would like to do it.
The people who really want to save lives feel like they're not always able to in the way they would like. And as a result, people's lives are at risk. I just know I couldn't do it emotionally. So I talked to Diane Williamson, who's the lead consultant in the emergency department, and I just asked her, how do you cope with this? Do you ever feel overwhelmed? Have you ever had a situation where you see the patients coming in, you know there isn't anywhere for them to go, you know it's very serious? How does that make you feel?
I think it's distressing. I would have to admit it's distressing, but I think the first thing that comes into play is a response. You know you need to do something, and so really the emotional part of it comes later. I think the first thing is that you've got to respond, and it's a team response. It's not one person.
And the senior managers that you spoke to there, what did they think the outlook was now? Are they over the worst of it?
I think the senior managers are trying to be optimistic, because they also know that their role is to make sure that the staff aren't totally demoralised. They have to give a sense of hope. But of course, things like the industrial action have made things even harder.
We went into November and the first half of December in some ways, a very strong position.
Roland Sinker, the chief executive.
And I suppose the winding period that we experienced was the Christmas to New Year period. Part of it was the distraction of industrial action.
Okay, so do you think the strikes compounded the problem?
Yes.
Okay, and what was the impact on the ground?
Yeah, so the impact on the ground of industrial action is we were looking to maintain really positive, constructive relationships with all of our staff, nurses, doctors, allied health professionals, assuming that this would continue for a while, and do all we could to bring patients in. And that takes an awful lot of one-to-one conversations with staff and a lot of colleagues in the unions to make sure that the services we were looking to exempt from strike action were the right ones. Right. And we were clearly pushing quite hard, but not wanting to overpush. That's a lot of time and energy that you would normally spend booking patients in for surgery or working out how to get patients home for Christmas and New Year.
And do you think patient care was affected?
Yes, definitely. Yeah.
And how did that manifest itself?
So it manifested itself in terms of really the elective cancellations that we saw for that period.
Okay, right. Yeah. And how has the cost of living crisis impacted you? Have you had nurses going to food banks?
Yes. Yeah.
Do you run a food bank here?
We certainly link into them, and we have a hardship fund that we do make available when people need it.
And when you talk about the flow through the whole system, where are those blockages occurring?
So I went to a meeting at 4:00.
With some numbers that are in the system as a basis.
There were all the people from the different departments from the hospital sitting around this big horseshoe table.
Which I then just adjust my calculation as they share it.
And on the wall there was this enormous spreadsheet with lots of numbers, patients moving here, there and everywhere, beds, which department was doing what, where was their space, where were their staff shortages, what was going on across the whole trust. So they're saying that there's 5 bed shortages in the ED department and it's likely to go up to 11 overnight.
So there's the issue at the moment is we've only got 3 decisions to admit. So we've got quite a full department and we would imagine that number would go up.
By that point, the data analyst was predicting there were going to be 11 beds short overnight. About 10% of their beds typically are taken up by people who are well enough to be discharged, and most of those are waiting for social care. And then staff shortages as well.
Essentially, we're also down 3 members of staff, so we've got 2 on the afternoon shift that are off sick. We've got 1 on the night shift that is off sick. Yeah. And so we are going to be spreading our staff to try and cover all of those areas, but obviously it just means that we're going to be a bit thinner on the ground. That's been escalated, obviously.
So the emergency department was 3 doctors down, and what happened in the end was that some of the doctors who were working just had to carry on and do a double shift. It was the only way to keep patients safe. At the same time, they were running through dozens of nurses off sick. So by that point, they were 27 nurses, 41 healthcare assistants down.
Critical incident, internal critical incident, which is OPAL level 3.
What does that mean?
It goes from OPAL 1 to 4, 4 being the highest level of pressure.
So you're on 3 out of 4.
We're on 3 out of 4 at the moment. A number of trusts across the region will be on 4 and have been for a long period of time. But what level 3 means is that we're not able to just place patients from the emergency department as soon as they need a bed, because as we talked about earlier, we're running at very high levels of inpatient occupancy.
What really struck me was that everything was interconnected. So somebody from patient transport was there, and they said that 2 of the vehicles that were due to take elderly patients back out to care homes hadn't turned up. So 1 had broken down and 1 had been sent out on a long distance drop, so hadn't been able to get back in time. As a result, these patients were going to miss the deadline for check-in to the care home. So they were going to potentially have another night on the ward. So the whole thing really is interconnected.
It's like the butterfly effect in a hospital.
Yeah.
One vehicle not working
Exactly.
will impact the whole system.
Yeah.
All the way up to A&E.
Yeah. It's just impossible for the hospital to operate in isolation. And in fact, a couple of senior managers said that they were thinking of buying their own care home or buying up places in a care home so that they had some more sense of control.
Their entire schedule wouldn't be messed up by them missing this one 4 p.m. deadline.
Yeah, there are so many things out of their control at the moment. But I think from the manager's point of view, they're trying to think of new strategies to slightly reduce the pressure on the clinicians. But they're also coping with the kind of facts of life outside the hospital. So the lack of social care, the ageing population, the obesity crisis that's creating a whole other set of problems, the difficulty that patients have in getting an appointment. So really, this has to be looked at as a whole system. And that strikes me more and more. We have to think about preventing sickness as well as dealing with sickness. You know, it has to be genuinely a national health service rather than a national hospital service. The hospitals are never going to survive unless we look at that whole thing all the way through from prevention and then also, of course, social care.
All the pressure shouldn't be at that acute stage. You should be looking at how people are fitter earlier.
Exactly.
And it does sound like the care system is such a big factor in how any hospital is running at the moment. You know, you described that backlog and how it impacts the entire flow of the hospital, you know, all the way up to A&E. Is there an argument that this is just something that should fall under the NHS? Or is it, I mean, is that just never going to happen?
I definitely think it has to be far more integrated, and you really can't fix one without fixing the other. The problem is the two systems are totally separate. They have completely different funding models. The politicians of all parties have really ignored social care because politically they think that hospitals and the NHS are where the voters want them to focus their attention. You know, Boris Johnson promised 40 new hospitals. That's not really what's needed. What's needed is to fix the social care system. It's 7:15 and we've been here about 10 hours now. Doctors and nurses are still working. Some have extended their shifts because there aren't enough staff. Some of their colleagues are off sick, so they're having to stay late to make sure there's somebody to look after the patients. The hospital is in what they call critical incident level 3 out of 4, and it's been like that for much of the last few weeks. You feel that the staff are really doing their best, but they're also exhausted. But it's just, for me, a sense also of how much time the really senior medical staff are spending on logistics, trying to make sure they can get a bed for their patients, and also feeling that they go home not feeling satisfied because they feel through no fault of their own that they haven't been able to look after their patients in the way that they've been trained to and that they would like to.
Coming up, the robot will see you now. Could technology help to alleviate the pressure on the NHS? That's in just a moment.
I'm Tony Gallagher, the editor of The Times. My team endeavours every day to bring you the best stories, the most incisive commentary, topical features, beautifully illustrated with award-winning photographs. But we can only do this thanks to the subscribers of The Times and Sunday Times.
Rachel, in the middle of all the chaos and the pressure that you witnessed at Addenbrooke's hospital, you did describe there were just these glimpses of what the future of hospitals in this country might look like. What are the great new innovations that we should be looking out for?
I actually watched a robot operating on a patient, removing a kidney tumour, and it was fascinating.
My name and title is Professor Grant Stewart. I'm the Professor of Surgical Oncology, which is cancer surgery.
It was like this enormous metal spider hovering over the bed.
The robot, part of it, attaches to those instruments and sits over the patient, a little bit like one of those car painting robots, painting cars in the factory. Meanwhile, the surgeon is sat on the other side of the room, actually controlling the instruments with their fingertips.
And he showed me, you look into a 3D console and it's incredibly realistic. You can see all the organs and all the tissue and blood. And he's operating these two pincers and cutters, a bit like a Xbox console, using these two joysticks.
So they look down a console that has a 3D view. So the view is excellent and allows very good depth perception, so you can work out where you need to move to pick things up and cut things. So
it actually makes the surgery easier?
Yeah, so it does make it easier. So for example, the instruments have 7 degrees of movement like the human wrist.
And he said it's at least as accurate as doing a traditional operation. Is there a version where the robot is programmed automatically and does it without a human being operating it?
No. So there isn't.
Is that the next step? Or?
I think that's quite a way off.
But the brilliant thing about it is the patient can get out of hospital much more quickly. Instead of having to stay in hospital for 4 or 5 days, this patient was going to be able to leave potentially within 24 hours.
And why is that? Why does it lead to a more efficient recovery?
So the hole that the surgeon has to make in the patient's tummy is smaller, and the instruments that they use cause less damage inside as well. And that's obviously good for the patient, but it's also good for the hospital because it frees up beds much, much more quickly.
I mean, that's so clearly a win-win. You've got to hope that this is something that's spreading across hospitals all over the country.
Exactly.
What else did they have that felt novel and new?
Well, they've been one of the first to introduce the virtual ward. Tell me your names for our tapes.
My name is Gemma Check. It's Gemma with a G.
And I'm Ian Goodhart, and I'm a doctor, and I'm a consultant in anaesthetics and intensive care, and I'm the clinical director for the virtual wards.
Some patients will go home with monitoring continuously or intermittently using our Bluetooth-enabled technology.
All the patients are at home with special equipment to take their own blood pressure, heart rate, temperature, and they're sent home with these devices, which are then linked back to the hospital automatically.
Okay, that's the key word there, stable. We send the patients home that are stable. We wouldn't send anyone home that was acutely unwell, where they needed to be in a physical bed. Everyone that we assess is suitable for the virtual ward.
At the moment, there are spaces for 30 patients on the virtual ward.
There's a group of patients whom they're here waiting to see how they're responding to treatment or waiting to see whether or not they deteriorate. And they're here because we're assessing their risk and keeping them safe. In our traditional thought process, keeping them safe. But actually, if we can monitor them, if we can allow them to move around, we can allow them to go home, we can still keep them safe because we're watching them, we're assessing their risk, we're seeing if they're improving or deteriorating, but we can also get them away from the risks of being in hospital.
Yeah.
For every day a patient's in bed, they lose muscle mass, they lose strength, they become more frail. We've got hospital-acquired infections, obstacles, noises. You can hear yourself, this is a noisy environment. It's a stressful environment.
And I spoke to Gemma Check, who is the senior nurse leading that ward, and she showed me the screen that she's looking at.
For example, this lady here is currently wearing a device to measure the temperature, so we can monitor her temperature continuously. So if we notice that her temperature had spiked up, we just give her a call, see how she's feeling, advise her to take some paracetamol, as long as she didn't have any other symptoms, and then she can just continue to be at home. So
the nurse looks at a screen on all the graphs of each of these measures that the patients are showing from home. And she said that the feedback from patients has been incredible. But what about for you as a nurse? Is it less satisfying if you're not actually having the human contact with the patient?
Do you know, the feedback that we've got from the patients makes me feel really proud. And actually all of the patients are just so happy to be home. And I visited one patient in her home actually, and her husband said, I'm just so glad to have her back. I didn't know what to do with myself in 4 days, because they'd been married for like 40 years. And so actually that made me feel really proud.
If they worry that there's a problem, they can bring the patient back in, but the patient in the meantime can be monitored, they say, safely from home. And it means that it's possible to look after a lot more patients at the same time, but also frees up the physical beds in the hospital.
That's incredible.
I worked in A&E for 10 years, so I've seen it all. We need the virtual ward to enable the patients on the wards to be able to go home. I think that if we don't try something new, then I just don't know what will happen to the NHS. You know,
it does feel like there is a real push towards moving patients out of hospitals. I mean, is that the future of the NHS?
I think it has to be. I think the hospital has to be the place where people go for emergency or acute care or surgery that can't be done anywhere else. But the more routine things, or monitoring or dealing with long-term conditions, has to be done at home. And technology enables that. It is possible now in a way it wasn't previously.
You know, a lot of people are talking about how to try and fix the NHS at the moment. One of the ideas that keeps being floated, and it's reappeared again recently from the former Health Secretary Sajid Javid, is just the idea of whether patients should be paying at some stage.
Mr. Javid wrote in The Times, "We should look on a cross-party basis at extending the contributory principle. This conversation will not be easy, but it can help the NHS ration its finite supply more effectively."
Having worked up close now with the health service, and I don't think the model of the NHS as it was set up some 70 years ago is sustainable for the future.
Having seen everything you saw at Addenbrooke's, what do you make of that policy suggestion?
There would be two problems that spring to mind. The first would be the practicalities.
What happens? So you turn up at A&E and we're asking you, well, that's going to be £10, please. I'm interested in how that model would work in practice.
Roland Sinker, the chief executive.
To say nothing of then, are people not coming to hospital, but then they come in by ambulance when they're unconscious, and then you deal with them, but they didn't want to spend the £10.
Several doctors have said to me they would worry that the poorest people would be the ones who would be put off seeking care until they were actually sicker, and then in the end that would end up being more expensive.
I just think there are other places we should be going first.
But I think it's important to look at all ideas at this stage.
Meanwhile, in government,
the government is making an announcement about the NHS today, and the Health and Care Minister, Helen Whately, is in our Westminster studio. Good morning.
Good morning.
When do you envisage getting back to the goal of 95% of people being seen in A&E within 4 hours? Because you're still only pledging to get that from the current 70% up to 76% in the next year.
You're right. So over the next year to make sure that hospitals are achieving 76% of that, I clearly want to see the service improve beyond that, but recognise that in its own right is a challenging,
how many more years do you think that will take?
Target. That's not a question that I can answer. But
the Health Secretary has announced this new plan to turn around emergency care. Steve Barclay said he wouldn't keep the target of seeing 95% of A&E patients within 4 hours.
We're not setting out that ambition in this statement because the impact of the pandemic has been so severe. We need to set an ambition which is a target that is ambitious but achievable, and that is what we have done.
What did staff at Addenbrooke's feel about that? Because I think for a lot of people hearing it, it's quite alarming. What do the medics make of it?
I think there is a, frustration perhaps among some of the clinicians that the NHS is always a political football.
It takes longer to get to those patients, and those time standards deteriorate. And what you'll see too is they'll be adjusted, and that's an interesting thing that I've watched a few times. Where instead of addressing the time and making it, and responding the time we should, sometimes the standard is changed.
Change the target.
Yes, it changed the target, and I think that's something that's quite interesting, and doesn't so that the reporting of the success in meeting the target.
What's so fascinating to me is that this is one of the best hospitals in the country. They're trying lots of new ideas, but at the same time, it's overwhelmed by the current pressures.
Can I ask you a stupid question?
No stupid questions.
The beeping that we're hearing, what does that indicate?
So
that's a call bell.
That's a call bell.
And that beeping there, a call bell that's been pressed by 1 or 2 patients on the ward.
But it's really stressful, isn't it? The noise just here.
This creates a sense of crisis, doesn't it?
It does.
The bleeping.
Yeah. And actually, we want to do the opposite.
Yeah.
To then look around and find yourself surrounded by the constant beeping sound of patient call bells. I mean, is that pretty much a metaphor for where the NHS is at the moment?
I think it is. It's just an incredible contrast. So it is like the hospital of the future, overwhelmed by the present.
So much of the NHS and the policy around it, you're right, has been very political. You're now running the Times Health Commission. Is that an attempt to remove the politics and look at what would actually work? I mean, what are you hoping to achieve with it?
I'm hoping that the Times Health Commission can be something that's above politics. We can step back and look at what is working already, what could work better, what technology can we harness to really take advantage of the modern world. So I think it allows us to step outside that political battleground and be pragmatic about it and follow the evidence and not have any prejudices, just look at the facts.
You've been listening to Stories of Our Times, a podcast brought to you thanks to the subscribers of The Times and The Sunday Times, with me, Manveen Rana, and my guest today, the columnist and chair of the Times Health Commission, Rachel Sylvester. The Commission will report back next January and will bring you all of their results, but over the course of the rest of this year, it'll be taking evidence from doctors, nurses and patients, as well as politicians and health officials. If you'd like to contribute, you can contact them on health.commission@thetimes.co.uk. The producer today was James Shield. The executive producer is Kate Ford. If you enjoyed this episode, please do leave us a review wherever you get your podcasts. Thanks for listening. See you tomorrow.